What is epilepsy? According to the English neurologist John Hewlin Jackson, who established the definition of epilepsy, where he had defined it as a sudden, rapid, and excessive discharge of the brain cells, when others defined it as a disorder of the brain. Until a few years ago, it was one of the diseases with the greater social stigma. Other people considered the disease was diabolical. Today, the increase of the sanitary culture and the general population has made this disease accepted and dismissified. Who has epilepsy? According to epilepsygroup.com, there are 60 million people around the world, about 2.7 in the United States. 75 people are diagnosed with epilepsy every day. Over the course of this year, 200,000 people in the United States have been diagnosed with epilepsy. Some are artists, celebrities, people that are heroes to us, even scientists like Vincent van Gogh, Theodore Roosevelt, Alexander the Great, Charles Dickens, Sir Isaac Newton, Thomas Edison, Julius Caesar, Harriet Tubman, Joan of Arc, amongst others. I've gone through a lot from the point that I was first diagnosed with epilepsy to present time today. I've gone to different doctors before I reached the NorthEast Regional Group, or the NEREG in Hackensack, New Jersey. This group of doctors have changed my life through the good times and the worst times of my life. And that is why I've taken the privilege of interviewing a few of the doctors of the group and even a long-time employee of the group. As an adult epileptologist, in 2007, when your patient, who is me, was in the ICU in a coma, what were your thoughts?
Every time a patient, go to the ICU, it's because, the situation needs more attention than usual. And, we all work together with the ICU doctors and all the team and the patient and the family to try to understand what the situation is and try to do everything possible to get the patient out from the ICU and go to the regular floor and then go home healthy. So, we really get very involved and put a lot of energy and effort to understand what's going on in order to help the patient. In 2009, when I was in surgery, did you see any changes in the progress of me, your patient?
Yes,
not only you did very well with the surgery, you had less seizures, but you were functioning, much better. And, we can tell because of all the good things you're doing now, academically you've been growing a lot, and that was very nice to see.
How do you feel when patients in general say that their progress is getting better, also when they say that the progress is getting worse?
Well, it's always nice to hear the patients are getting better, and that's why we are here to make the patients get better. Unfortunately, not always. That is not always possible. Sometimes patients get worse, and when that happens, we need to put all the energy to understand why that happens, and try to reverse the situation so the patient can get better then.
Thank you. What is your message for people who don't understand what is epilepsy?
Well, there are many people that don't know what epilepsy is, even though in the last many years there's been a lot of education and people know much more than before. There's still a lot of work to be done. Many people don't know what epilepsy is. They have significant misconceptions about epilepsy. They think that that's something contagious or associated with different things that are not true. So it's our role and the patients and the families to educate the rest of the population about the epilepsy.
What would you say to people who treat patients differently because they are epileptic in school and out of school?
Again, I think part of that is related to ignorance. Many people are not educated. They don't know what epilepsy is. They have misconceptions with that. That doesn't justify treating someone bad, and that should not happen and should not be allowed to happen in any school or at work. That's kind of discrimination should not happen, and but I think it's very important to do a lot of education, but at the same time make sure those things don't happen.
Thank you, Doctor. The first goal that you have for different patients and their families.
Right. So the first thing that everybody who has coming in to see me is to make them go away as soon as possible. That's really what they want to do and rush into as soon as possible. But the first goal that I have as their physician is really not that, because the really most important thing for them to do is really begin to understand what it is. What is a seizure? Where does it come from? We try to describe that it's abnormal electrical activity from the brain, that the brain could be otherwise healthy and just has too much electrical activity. We talk about the reasons why that could be the case. We talk about the fact that we're going to be looking into why their particular child had that burst of abnormal electrical activity, and then looking into reasons as to why that may or may not occur again. We talk about tests we might do, but that we don't have to do every single test for every single patient. Sometimes parents are very worried that we're going to do a whole slew of tests that may be painful or uncomfortable for their child, but not every child needs all those tests, and we really try to make it individualized to every patient. And the most important thing is education. What's a seizure? Is it harmful? What are we going to do about it? Do we need to treat it? How likely is it going to happen again? So even though parents are in a rush to make it go away and never see it again, I don't know all the answer to that question initially, but I need them to know all the answers to those questions so that they can properly take care of it and begin to understand what it is, why it happened, and what we're going to do about it in the future. Well, one issue that doctors have when patients tell us they're getting better, we're of course very enthusiastic, and that's of course what we want for everybody too. However, we don't yet know if the process has run its course, if they're still at risk of further seizures. And so we don't want them to get too much enthusiasm too quickly. It's a common problem in medicine that patients get enthusiastic and, for example, stop their treatment, or let their guard down and, for example, start staying up very late, which might because of sleep deprivation, make them at more risk for seizures. Or may, for example, start driving again when we've asked them not to wait a certain amount of time. So we're always optimistic because of course we want patients to get better, but on the other hand we have to remind people, wait a second, what got you better is all the things you're doing. You're taking your medicines, you're on a regular sleep-wake cycle, you're watching how much maybe, for example, you drink or exposed to illnesses and things like that. And those things need to continue to keep you healthy. And that's what's really important. Just so people don't stop doing those things and have the epilepsy come back. Now, if things are worse, we have to look at everything that might be making it worse. Maybe, for example, people did kind of relax a little bit on the things that made them healthy. Are they taking their meds every day? Is there a way we can help them do that? Say, for example, some medications you can take just once a day. Or help them with reminders about their medications. There's apps to help you remember to take your medications. There's pill boxes to help you take your medicines. We could check their levels to make sure they're still in there. Are they on a different medication that maybe lowered their meds? A common one with young women is like oral contraceptives, which may have lowered their dose of their medication. Have they started a new job, like say maybe an overnight job, that lowered their sleep, maybe make the seizures worse? So we really look at everything in their life and in their medicine taking that may have changed what they're doing to make the epilepsy worse. And especially in children, the epilepsy itself can change. As the brain develops, the epilepsy can develop. So if we've reviewed those other factors, med factors, life factors, then we may actually redo some of our testings, EEGs or MRIs, to see has the brain developed so that the epilepsy's changed. Maybe we're treating it the wrong way. Maybe we need to look into a different treatment. Maybe what worked when the child was younger doesn't work anymore, and we need to look at our approach. So we never stop investigating as to why a patient is either getting better or getting worse, constantly working with the patient and the caregivers to get them the best possible care that they can.
What is your message for people who don't understand what epilepsy is?
A lot of people don't understand what epilepsy is. Recent studies have come out and said that if you poll teenagers, they think it's contagious, and that's not true at all. They think that anybody who has it might be dangerous or aggressive around them, and that's not true at all. And that's just really a lack of education. So we all need to do our part in terms of demystifying it from something that's scary and something that scares other people, to just let people know it's just a disorder. You know, it's a very common disorder. It's present in probably 10 to 25% of the population. What I tell parents and other caregivers is that in a large school, if it's there in 10 to 25%, pretty well someone in every grade has epilepsy. If they say, well, I don't know a child, I'll say, yes, that's true. You don't know the child who has it, but there is a child who does. These children, they look normal. They look no different from everybody else. And neither does a child who has diabetes, or a child who has high blood pressure, or a child who has a kidney disorder or a heart disorder. In other words, there's lots of diseases that people can have, and they look perfectly fine, and they can function perfectly well. So we need to demystify it from what it is and just extend some courtesy and some further education. I do a lot of work with the Epilepsy Foundation in both a local level as well as the national level to try to get that message out. It's not something to be afraid about. Lots of people have it, and we need to not stigmatize people with the disorder.
What would you say when people treat these patients differently because they have epilepsy in and outside of school?
Yes. Well, we all know that unfortunately, because of human nature, but that does happen, and it's very sad. One thing that I have said to different groups that I've spoken to is I ask them, if you see somebody walk by who has dark glasses on and a cane and is obviously blind, would you treat them differently and be unkind to them? If you see somebody in a wheelchair and know that they can't walk, would you treat them differently and be unkind to them? If you see somebody using sign language and know that they can't hear, would you be unkind to them and treat them differently? People usually look in horror and say, no, I would never do that. I said, then why would you treat someone with a condition that you can't see unkind and differently? Because it's absolutely no different. And I think as a society we have to move beyond showing charity to those who have disabilities that we can see, to extend that to people who have conditions that we can't see. Because what we know is those are causing hardships to people, but they're showing tremendous courage, tremendous bravery to go through their everyday lives trying to have as regular a day as everyone else, even with their condition. And so we need to show them some just common courtesy and accommodation that they have as well. And again, we're just trying to get that message out. Just because you can't see their condition does not mean you shouldn't show them charity, patience, kindness, as you would with anyone else.
What is your view on when patients are given the wrong information about epilepsy?
Wow, I cannot tell you how often this happens. TV shows will show someone with epilepsy and somebody putting something in their mouth, which actually can damage their teeth and cause them to choke. Sometimes patients go to the emergency room and a physician or nurse will tell them the exact wrong thing to do. This is a message that can be very, very, very wrong. And we often have to go back and dispel this notion. Again, working with the Epilepsy Foundation, working with our patients, try to give them literature, try to give them information to say, hey, you know, a lot of these things are just old wives' tales, common misperceptions. You cannot swallow your tongue. I beg you to give it a try because I guarantee you it's attached. Don't need to do these things. There's a lot of good literature and information where you can look this up. We can come to schools and do teaching. We can come to community groups and do teaching. But it's a constant effort really to raise people's awareness. You know, epilepsy has been described as old as the Bible, as the Torah in ancient Egypt. And it was described as people being possessed. You know, we've gone a long decades and millennia since that time, and we need to have people move on and just know it's a brain having just too much electrical activity and how to appropriately respond to people having it.
What is the usual time range that most of the children patients grow out of having seizures?
That's a great question, and that's what makes taking care of children such an exciting and happy thing to do, and I'm so glad I chose this profession. It all depends on the type of epilepsy and when it starts. There are many conditions such as febrile seizures in children where most children will grow out of it, usually by 3 years of age. There are conditions in early childhood where babies will have seizures and often grow out of it by 2 years of life. There are other conditions that start usually around kindergarten age, something called absence epilepsy, another condition called benign Rolandic epilepsy. These are very common and genetic kinds of epilepsies that are always go away by puberty. Unfortunately, there's other kinds of epilepsy that are a little bit more serious that we can't predict will actually go away and sometimes get worse. Again, when I started, you asked me rather about what I do first, and I talk about education and finding out what's going on. That's why it's so important, because we need to find out what that patient has, what kind of seizures, what kind of epilepsy, and allows us to make those predictions about what it's going to possibly be like and when the epilepsy is going to go away. We're not 100%, we can't make guarantees, but a lot of epilepsies that begin in childhood will probably go away by puberty.
How do you mentally prepare your patients on what they're going to go through as a person who's going to have epilepsy and for the future, and also if they're starting to have epilepsy now?
Okay, that's a good question. I mean, when patients are typically come to see me as a neuropsychologist, I'm going to take a look and see how their cognitive functioning is. So, but I'm also taking a look at their emotional functioning too. So what I'm trying to do is explain things to them, give them sort of a roadmap for the future, right? So I'm trying to explain to them, well, this is how these seizures can affect how your brain is working, how it can affect your attention span, how it can affect your language, how it can affect your memory, and then we can talk about how to address that, different kinds of recommendations I might have. We can talk a little bit about the future. We can talk about how well seizure control can impact you in terms of your cognitive functioning, how it's going to impact your quality of life, if there's a possibility of the seizures being treated completely, and the medication working and actually lowering the seizures completely. We can also talk about their emotional functioning, again, about how signs of depression and anger and frustration and anxiety and all these things are very common amongst people who have a history of seizures, that it's normal and expected. And then, not only that, but there's things that you can do about it, that you don't necessarily have to be left alone, that you can go and see a therapist and talk about it, or perhaps join a support group and hear from other people. So again, you don't feel alone, but hear also how they're dealing with their problems as well. Or maybe you need a referral to a psychiatrist to help address these issues with depression and anxiety. So basically, my job is to help the person get an understanding of how they're doing cognitively, emotionally, and also get that information to figure out what to do with it and what kind of recommendations I have to address any kind of issues, but also with it again, with an eye towards the future, and knowing that all of these things can be handled, although not necessarily the way the person thinks. That is to say that their life might be different from the way that they planned originally, but that doesn't necessarily mean that they're going sort of into a dead end. There's still things the person can do with their life. We try to emphasize that point whenever anybody comes in to see us.
As a neuropsychologist,
Right.
For the PNS,
Right.
is there a process in knowing whether a patient has seizures because of epilepsy,
Right.
or is it from PNS?
That's a very good question. And also we should keep in mind is it doesn't necessarily have to be one or the other. There are some people who have both. They have both epileptic seizures and non-epileptic seizures. And for those people, it gets a little more complicated in terms of treatment. But I just wanted to make sure that point is there, that one doesn't necessarily include the other. But to answer your question as to how do we determine that, I mean, usually the first step is visiting with the neurologist. The neurologist is going to do a long interview and also do some studies, usually an EEG, or what we call video EEG, and then they'll do some monitoring, and using that, they can figure out if the seizure, if they actually have a seizure during the course of the monitoring, is epileptic or non-epileptic. And then if it is non-epileptic, the person gets referred to somebody like me. So my job is to sit down with them and do a lot of tests with them and see how their cognitive functioning is, but also their emotional functioning too. Because usually when somebody has a history of PNES, it's not uncommon for there to be a history of abuse there. Abuse or some sort of chronic stressors in their life, whether it's kids or adults. So we're going to take a look at that. We're going to take a look at that through history, again, an interview. We like asking lots of questions, and also take a look at their records, and also having them fill out questionnaires, and sometimes having family members fill out questionnaires. And using all that information, we can get a sense of how that person is doing psychologically, and then we can get some pretty good evidence that tells us that the seizures seem to be non-epileptic in origin because the person has all these psychological factors. And also there's certain findings and indices. We're looking for something that's a process called somatization, which is when a person tends to experience physical symptoms in times of stress, which is what PNES is. It's a form of physical reaction to stress. So, so my job is a step after meeting with the neurologist to meet with the person and get, again, a lot of information that helps fill in some of those gaps about how they're doing psychologically and emotionally. And that, in turn, helps us figure out about treatment, what to focus on in terms of the treatment.
Is there a way of knowing that medicines can give patients, if it affects them emotionally?
Right? That's a very good question. As with any medications, there's certainly going to be side effects, right? And certain anti-epileptic medications are more associated with those side effects that you're talking about. Some emotional ups and downs, irritability, depressed mood, anxiety, things like that. So without getting into the specifics, clearly there are some medications that are more associated with that, right? But it is a complicated question. When somebody comes into us, we're doing that history. We're asking a lot of questions. So we want to know what's going on in the person's life, what sort of stressors there are. What is the person doing with their time? Are they working? Are they going to school? How do the seizures impact their ability to do those things? How are they getting along with family? How are their other relationships? How are they doing financially? How are they doing just in their day-to-day activities, just be able to take care of paperwork or housework or things like that. All these things can be frustrating. So using all that information, plus again, questionnaires, we can see what kind of levels they're at. We can see what kind of levels of depression or anxiety or anger and so forth. And then combined with that, looking at their medications, we can kind of figure out how much is one or the other. It's hard because we're not really necessarily getting any hard numbers, but we're relying on our clinical judgment. How much is this due to the medications, and how much is this due to life circumstances?
In what ways psychologically do you help patients who have been bullied or discriminated because they are epileptic or have seizures?
Well, let's see. I mean, as a neuropsychologist, I don't really do therapy per se. However, I will tell you that when people come in, particularly kids, it's not uncommon for me to hear that. So just for them coming in and hearing from somebody who will accept that and tell them, yes, we do see that is not uncommon, and no, that is not acceptable, and we need to figure out some way to make sure that doesn't happen again. Part of our job is working with the parents to figure out what has been done about that. Is the school aware? Is the school working on that? What is the child doing in terms of being able to stand up for themselves? Are they having any sort of therapy that's helping them be able to cope with it too? So again, our job is to ask a lot of questions and just to see what kind of services are being done, what sort of accommodations, what sort of work is being done in the school or in the community for that matter to address exactly that. So we're not necessarily going to get the ball rolling per se in terms of making sure things get going. That's really usually the parents or the individual's job. But we can ask the right questions to get them thinking in that direction. And also just to tell them too that, being bullied, whether work or school, is enormous weight. It carries enormous weight on a person. Just to tell them, sometimes therapy is necessary to work through that. Because again, those stressors have an impact on the person and affects their functioning. So we're trying to normalize the idea of therapy. There can be a stigma against that. So we're trying to make sure that the person knows that going to talk to somebody who isn't necessarily a friend or a family, an objective person who isn't necessarily involved in your life, can give you a perspective on things that you might not get otherwise. It can give you some insight that can be really helpful for you.
Thank you.
Okay.
I'm not sure if it's the correct question because it might probably be therapy also. But for patients that are asked to be operated on,
Right.
what is your major goal to get them to stay calm?
Okay, now this is still a fair question for me actually, because I do see quite a few patients who are being considered for surgery, right? First of all, we're trying to give them some information and remind them about the questions that they should be asking, right? Not only of their neurosurgeon, but also of their neurologist. What are the odds of the surgery helping me? What are the odds of the seizures again going away completely versus decreasing in frequency versus not changing at all? So we want to get those questions answered. But also my job is to help them figure out if they do go ahead with the surgery, what kind of changes they can expect in their life. Again, in terms of depending on where the surgery is done in their brain, we can get an idea of how that might affect them cognitively. What changes might they expect in terms of their attention span, or their memory, or their language, and so forth too. And sometimes it bodes well for the future. Depending on what area of the brain it is, we can tell them that this is, relatively speaking, a good area to have surgery. That it bodes well in terms of how you'll be doing cognitively in the future. But again, just to remind them that this is a huge decision. So maybe, not necessarily remaining calm is to be expected, right? This is a huge decision. And for them to weigh everything, to weigh all the information that they get from people, and then make the right decision. We're talking about quality of life here. Deciding to undergo surgery is a huge, huge decision. So we want them to get as much information as they can. So I would argue that maybe the question would be, how can we help them be more knowledgeable about making this huge decision? Not necessarily calm is a good thing, but we definitely want them to be knowledgeable so that they can make the best decision for themselves. And that's why they meet with all these providers, all these doctors, and people like me, and the neurologists, and the neurosurgeons, and so forth. Because they want to give them as much information as they can to decide if this is the decision that's going to help them change their life.
Work the epilepsy group, you have seen a lot of patients. How have you seen the growth of the patients that have come to see the different doctors of the epilepsy group?
Since we started in 1998, the group has grown. We have now a pediatrics department and an adult department. We've seen a lot of patients since we started in 1998. When I started with Dr. Lampin, Dr. Lambrakis, and then Dr. Laban joined in our practice. There's been a lot of success stories. A lot of patients that have surgeries and been seizure-free and have lived a normal life and done well.
And
seizure-free and have lived a normal life and done well.
And me as a patient that has been coming for years to Dr. Lankman, how have you seen my progress grow from when I started and now and this time?
Since you came here, when you came here, I remember your mom used to come in and she would cry because you had so many seizures. And we did our workup for surgical because you became a surgical candidate, and they did the surgery and it was a success. I've seen your progress. You have improved tremendously, that you have been able to go to college, graduate, and do well.
And what is your thought of when you hear that from the different doctors that come and say of the different patients that are getting better or getting worse?
We have some of both. Some of them, their seizures come from all over, so there's really not many options but medications or VNS or something else but there's a lot of new medications that are in the market that have helped some of the patients that cannot have surgeries. But we have pretty much a good few of success stories. Help some of the patients that cannot have surgeries. But we have pretty much a good few of success stories.
And what is your thoughts upon when you hear that a patient has been discriminated because they have epilepsy?
I get very upset. Very upset that I wish I would be able to have any kind of power to not, for them not to be discriminated upon, because it's not something that is contagious. It's not something that they should be discriminated upon. It's something that they have and they can't control it, and they should be helped instead of being looked at in different ways.
When you hear that people are given bad information about what is epilepsy, what is your thoughts upon that?
We usually don't try to like do. We usually try to give them positive feedback, and we try to explain to them exactly what it is, because some of the parents come here and they think it's something like really bad, but it's not. It's something that is treatable, and the doctors take their time and explain to them what are the options and what they can do, the studies that are out there that they can do, the medications that are available, the testing that we can do to see if it's a type of epilepsy that could be cured as they grow up, or something that could be treatable or surgically done. There's surgical options that could be done that would eliminate the seizures.
Okay. Padre de una hija que tiene epilepsia, tú la proteges en la escuela y afuera de la escuela.
Bueno, lo que siempre hemos tratado de hacer es tener en la escuela las personas que están cerca de ella el conocimiento de su condición, para que en un momento dado, si le sucede, alguien pueda socorrerla rápidamente. Además, estar preparados para en su momento inmediatamente asistir a la escuela para buscarla y protegerla en cualquier ataque.
Gracias. ¿Cómo fue tu respuesta cuando los doctores te dijeron la primera vez que tu hija tenía epilepsia?
Bueno, confiamos en los conocimientos que ellas tenían. Gracias a Dios asistió a una de las hospitales más preparadas para el tratamiento de niños con este tipo de mal, y confiamos en lo que ellos podrían hacer y le dimos nuestro apoyo en cada momento.
Dice a un padre que tiene hijo que tiene epilepsia, que ellos tienen tiempo duro, que ellos lo están tratando mal en la escuela.
Bueno, hay que armarse de paciencia, tener mucha paciencia, y a sus niños defenderlo ante todos y ante todo, porque este es un mal que le aqueja. La niña no lo pidió, nosotros no lo pedimos, eso vino por la naturaleza, y tenemos que estar siempre pendientes para defenderlo en cada momento, porque estos son ángeles que nos manda el Señor para que los cuidemos.
Como madre, ¿cómo tú recibiste la noticia que tu hija tenía epilepsia?
Como madre, Recibí un duro golpe cuando escuché la palabra epilepsia. El mundo se me vino encima y pensé, wow, epilepsia. Pero ¿y por qué? A mi hija, ¿por qué? Y de ahí en adelante mi vida cambió. Nunca fui la persona de antes, nunca más volví a ser la misma persona, ya que no podía dormir tranquila. Siempre me levantaba a dar vueltas, a ver cómo estaba mi hija. Algunas veces dejaba mi habitación y venía y me acostaba junto con ella porque tenía miedo de volverla a ver en las condiciones que la vi el primer día que le dio el ataque de epilepsia.
Padre, ¿cómo tú has defendido a tu hija en la escuela y afuera de la escuela?
Como madre, he defendido a mi hija con uñas y dientes, defendiéndola de todas las personas que han querido discriminármela, tanto en la escuela como fuera de la escuela. Cuando mi hija estaba en la escuela primaria, una de las profesoras hizo que los compañeros de clase de Elizabeth como que le cogieran miedo, y consideré que no era posible que una educadora actuara de esa forma y que me pusiera a mi hija en esas condiciones. Mi hija estaba nerviosa, casi no quería ir a la escuela. La profesora insistía en que mi hija debía de ir a clases especiales.
How did you react when you first heard that your sister had epilepsy?
I actually was in the room when she first had her episode. I never seen it before, so when I heard her shaking, I thought originally it was just because she was in the middle of sleep and she started shaking the bed. But then when I turned on the light, I noticed that she was seizing, and I immediately freaked out. I didn't know what to do, so I called my mom and my dad. So my basic reaction was freaking out because I've never seen this happen before. Not even in movies. I didn't know what was a seizure. I just thought, it was something that only happened basically to her. But as I started to learn, I realized it's more common than I thought.
Epilepsy took a toll on my life through the good and the bad. In every level of school I have taken, from elementary school, high school, college. As a person who has epilepsy, I also have been discriminated in finding a job. After graduating my first time out of college, I have been discriminated trying to find a job in communication. I also had tried to find jobs elsewhere besides communications, trying to see if I could find a job at an office, and still have been discriminated.